Uh, Dr. Patni had told me that you got to make a crisp talk, because when we any two items, when you have pakoras and you have dosas, they always liked when they're crisp, when they get soft, they become boring. So I'm trying to make a very crisp presentation today. And the next aspect, these are the acknowledgements. And the other aspect which I would like to talk is because of food, shifts, and festivals. So when I looked up the AI and I asked the AI how many festivals do we have in India, so it came up with about 56, and they said there may be more than that. So if I have to make a diet for each festival and from all the four corners of India, I think we could spend the whole evening discussing what should be eaten. So, so I thought if we could actually plan out the diet, give you the tips of how to plan a CKM diet, then any diet, whatever be the condition, it becomes very easy to follow that. And we know that dietary intervention actually delays the progress of CKD and CKM syndrome as a whole. And most of these patients have a lot of comorbidities which interfere with the diet prescription, and this leads to poor adherence of the diet. And as Dr. Patni had said, that as a lifestyle intervention, all the caregivers, along with the patient, we should have frequent interactions, and the person who is giving the advice should be well versed with the medical nutrition therapy. And instead of giving a generalized dietary intervention, we have to be patient-centric and individualized. And regarding the paradigm shift in the recent decade from managing specific nutrients towards a broader outlook of whole dietary pattern is what is the trend at present. Because earlier we used to say person with a kidney disease, okay, you don't have more proteins, have more carbohydrates, less salt. You can have salt substitutes, where they basically individual ingredients were targeted. And as I said, once you know the basic principles, you can prepare a veg, non-veg diet, a festival diet, a rich man or poor man's diet, or a shift worker's diet. What are the key focus areas in the CKM diet? Basically, we need to restrict the sodium intake to less than 5 grams per day. We need to manage the protein intake, keep it around 0.6 to 0.8 grams per kg per day, and if the patient is on dialysis or is having protein malnutrition, then it can be on the higher side. Also, we need to lower the potassium and phosphorus. What are the key Indian foods we need to include in a diet? White rice, poha, low sodium bread, fruits such as apple, papaya, guava, the vegetables, cabbage, cauliflower, lauki, bitter gourd, and there are many more depending on the local produce. Foods we need to avoid are the green leafy vegetables, raw bananas, potatoes, even the sweet potatoes, tomatoes, beetroot. Avoid fruits such as banana, orange, coconut water, kiwi, avocados, and also we must include rajma, chole, nuts, seeds, processed and packaged food, pickles, and brown rice. We always say brown rice is good for your health, and there's a trend now people consuming more brown rice, but that is basically high on phosphorus. Looking at some of the do's and don'ts, basically when you make a diet chart, it should be in the local language and it should be easy to understand. Portion sizes should be explained properly. The patient should be taught to read the menu and food labels, which is very important in these days of packaged fooding. And we should use healthy and safe cooking practices, and this should be conveyed to the main person who does the cooking for the family. We need to use eye-catching images of local foods and their nutritional values, and repeat counseling time and again to get a proper and better adherence of the diet by modifying it from time to time is very important, and we must have access to expert advice when required. We need to also keep an eye on the fluid restrictions as to what basically constitute the fluid intake throughout the day. It's not just water, but there are other food that we take throughout the days, which also should be included as a fluid intake, and that restriction is important, especially if the patient is having a heart failure or he is under fluid restriction. And we should limit simple sugars, of course, in diabetics very much. We should avoid excess salt and salt substitutes. Foods high in sodium, potassium, phosphorus, and monosodium glutamate, especially used in Chinese foods. We should avoid processed food, pickles, ready-to-eat foods, sauces, herbal products, fruit juices, and beverages. So what would a typical Indian diet look like? For a breakfast, we could have upma or wheat upma. For a non-veg, we can add egg white. Suji, idli, poha, chutney with reduced salt. For lunch or dinner, white rice or roti with vegetables, lauki, tinda, turi and cabbage, cauliflower, a bowl of moong dal and curd, preferably non-dairy milk can be used. You can give them fruits such as apple, pears, papaya, guava, pineapple. Tea and coffee can be had as per his requirement, of course, without sugar in diabetics and using non-dairy creamers. And for snacks, foxnut or makhana and millet biscuit would suffice. There's a lot of controversy nowadays whether should patients with CKM shift onto a vegetarian diet or continue with his non-veg diet. The choice is all ours actually. Our constitution guarantees freedom of diet choice. So we need to leave the patient to decide what he wants to have. But plant-based diets are increasingly recommended for better cardiovascular and kidney health because they help to improve the gut microbiota and also help maintain the nitrogen balance. They support better acid-base metabolism, bone mineral health. They produce fewer uremic toxins. And actually, when non-veg diet, you have to use a lot of salt and saturated fat to prepare the non-veg diet. So if on a vegetarian diet, you reduce salt and saturated fat intake. Plant proteins are acid neutral or alkaline producing, unlike the animal proteins that increase dietary acid load. Animal proteins may cause higher glomerular hyperfiltration. And plant-based meals lower serum phosphate, reduce the urinary phosphate excretion and fibroblast growth factor 23 levels. Actually, in CKD patients, higher levels of growth factor 23 levels actually affects the prognosis. And so the lower it is, the better it is for the patient for the long term. Coming to the dietary fats, we know dyslipidemia develops as GFR declines. The American Heart Association recommends 25 to 35% of total calories in the form of fat, of which MUFA should be about 20% and PUFA up to 10%. Saturated fats less than 7 and trans fat less than 1. We should avoid repeat heating or reusing of cooking oil to reduce the trans fats, of course. And of course, patients with high cholesterol, they should restrict it to less than 200 milligrams per day. Oil rotation is also important, and combining all the proteins diet together along with carbohydrate and proteins, we can actually produce the patient with a fairly good fat intake. Coming to the carbohydrate intake and glycemic control, when protein intake is restricted, we need to provide energy to the patient, so carbohydrate comes into the picture. Adequate carbohydrates help to prevent starvation ketosis and spares the body protein. They also provide good amount of dietary fibers. Suitable foods are the rice, poha, dalia, wheat flour, porridge, suji upma or suji chilla and dal or sabudana dal rather, we could say that. Cereal should be combined with pulses, peas, milk and milk products to improve the protein quality. And small and frequent meals are recommended. Sabudana has low protein, negligible phosphorus and can be included in different recipes to make rotis along with arrowroot or rice flour and also to make desserts, which will improve the palatability and calorie intake of the diet. About 25 to 30 grams of daily fiber is recommended for a CKM diet, and the advantage being that we know that fibers prevent constipation, improve the gut microbiota and also provides satiety. Coming to the potassium in the CKM diet, bale fruit, green leafy vegetables, coconut water, fruit juices, vegetable soups, salt substitutes should be avoided in advanced CKD, but that restriction is not required in mild to moderate CKD. Spices and condiments may be used in controlled portions. After considering the potassium contents, garlic, hing, methi dana and turmeric helps to improve the taste in low salt diets. Dhania, jeera and red chili powder can be used as flavoring agents. Of course, we need more Indian data on potassium bioavailability because we have actually so many flavoring agents and so many other these ingredients being used in different parts of the country that we do not have adequate data actually. We need to make more of these potassium bioavailability data so that we can select food from different parts of the country and advise it in the CKM diet. Coming to the phosphorus in CKM diet, animal proteins have higher phosphorus bioavailability compared to plant proteins, and plant phosphorus is less absorbable due to the phytates, that is, thereby helping the phosphorus restriction. Processed foods such as colas, enhanced meats, frozen meals, processed cheeses, instant foods and bakery items contain high inorganic phosphorus. And inorganic phosphorus in processed food has about 90% bioavailability, and in food additives about 100%. So we should teach the patient to read food labels and check the PHOS phos to identify hidden sources of phosphorus. Some of the common myths regarding dietary restrictions are salt substitutes. People can say if you can't use ordinary salt, you can use potassium salt or low sodium salt, senda namak, but they are also rich in potassium and lead to hyperkalemia. Also anemia in CKD patients. People think that pomegranate, orange, lime juice or carrot and beetroot juices will actually help to increase the hemoglobin level, but that is not the mechanism, and they are high in potassium and may cause glycemic spikes. Avoiding all protein sources is another myth because it can lead to protein malnutrition, so the correct quality and quantity of protein is essential. Dietary amino acid patterns influence CKD risk, so that also must be kept in mind by combining different foods. Fruits and vegetables should not be completely avoided. Leaching is required only if there is hyperkalemia, as it causes nutrient loss, mainly water-soluble vitamins. Fluid restriction includes all liquids, not only drinking water, and this allowances has to be individualized depending on the comorbid conditions. In early CKD with normal urine output, water intake may be liberal unless fluid overload occurs. So the take-home message for today's talk is that diet should be individualized and patient-centric. And once you know the basic principles, prescribing a diet for any occasion becomes easy. Acceptability, availability, and affordability must be factored in. And frequent interaction with the patient and caregivers is of utmost importance if dietary intervention is to succeed. And those who are actually giving this dietary knowledge should be well versed with the medical nutrition therapy to handle CKM patients. Thank you.